Hello again. We'll just continue with what we have left out in the class for assessing the case study, which is about the bone lesion. And today I'll be focusing on certain factors, important key factors, which is going to give you some insight about focusing on the case study that is we started discussing about the issues. Okay, so I'll go with one by one. So metastatic static cases are like disease which accounts for majority of malignant bone lesions, especially over the age of 40. So this is like 90% of the cases, and 10% primary tumors is also possible, and 3 to 5% myeloma cases is also possible in these kind of cases, because when you see it in the primary bone cancers, which is probably relatively rare, and the more small fraction of all bone malignancies might start over here, because I told you in the class there are certain pit cases, pit related fractures are there, which happens would have happened like very long back, and the patient might not have focused on that particular problem. What happened at after like years, when the pit becomes too deep, then it will create contingencies kind of a factor, which will make the bone become very like brittle, and which will you move on to mutagenicity. And once the mutagenicity happens, the healthy cells get the possibility of getting into carcinogen, and the carcinogenicity will also happen at a rapid period of time. But the stage 1 and stage 2 probably will not showcase any kind of differences in that particular patient's level. We can able to find out in the stage 3 or more. And in the myeloma cases, it is like a multiple myeloma, which represent a distinct category which separates both the primary and the metastatic bone cancers. And if you see unmasking these kind of lesions through radiographic clues, the first thing is like lytic lesions, then the blastic lesion, and the mixed lesion. So in the lytic lesion, if you see, areas of the bone breakdown appears as dark destructive regions on x-ray, as I shown you some images in the classroom. So which is like very common in multiple myeloma. Metastatic kidney and thyroid cancers will also be a part of it, and which will create the primary bone tumor. So this is the case number 1. And in the case number 2, blastic lesions, if you see, the area of increased bone formation appear dense and cyanotic on imaging, which can also be a deteriorated one, which has the most characteristics of prostate cancer, which is metastasis again, but also seen in some kind of breast cancer too, which is not only affecting these kind of bones here. And in the mixed lesions, it is the combination of the first two factors, and if which is seen in various metastatic cancers also, particularly breast cancer, metastasis to the bone, which will lead to a fringent kind of cases. And the clinical features about certain things, I just wanted to showcase it here. Like, I'll go one by one. So multiple myeloma is kind of a typical case over the adult of 60 years of age, but these days I have seen in most of the research papers that it is showing like it has come down, and in the range of like 45 it has become average, and it is happening. So the next one is like indigenous set of one set of bone pain will also be there. Obviously these kind of all problem will lead to the bone pain. And the pathological fractures without trauma, that's why it become very pit, and nobody knows it in the years, and when it kind of an acute, only the chronic condition will be able to address it. And in the next one is like anemia and fatigue, which also be a part of this, and renal dysfunction will also be a part of it, and hypercalcemia symptoms, which is like having some kind of bone disorders, and elevated serum protection will also be a part of this, because whenever when you go for an hospital, when you assess some kind of thing, usually they do take the serum test also with respect to the pathogenical conditions, with respect to the bone problems. So these kind of problem will tell you like what is happening with the body. And the next one is like primary bone tumors. So this is like osteosarcoma, which is like peak in the age of 10 to 30 years, and then chondrosarcoma, which happens usually in the age of adult from 40 to 70 years of age, and Ewing sarcoma, which is like children and young adults. So localized pain is also seen in this most of the cases with respect to the swelling and the progressive symptoms. Usually it is like it will take its own time to show it as a symptom in the body, and and then the last one is like off and ear growth plates. That what they're trying to do is like if there are like any implants being introduced into the body, and at the first stage it will not be considered as a foreign body, but after a period of time it is considered as a pathogen, and the WBC started to attack that particular implant, because the autoimmune issues will also occur in kind of cases with treating that as a foreign body, which will create these kind of problems, and sometimes which will lead to cancer, because the tissue get damaged, the cells will get mutated. Once it is getting mutated, it will move on to the next stage is called carcinogen. It will become a carcinogen, and that will lead to carcinogenicity, and it slowly move on to the progressive state, and which will end up in having primary bone tumors. Okay, the last one is like metastatic disease. Again, it is like typically older adults will be a victim for these kind of cases, followed by a history of known primary cancers, maybe because usually the occurrence of cancer might be always be a part of any type of cancer. Once we try to cure it, if the patient is like responding better, and they'll come out of the cancer, but the doctor will not provide you the assurance that it will not happen in the future. So the metastatic disease or something like that, even though if we treat it and if we eradicate it completely, there might be a tiny occurrence which might happen in the near future, and we will not be known like why that is happening, but it usually happens like 1 to 5% of the people. Then multiple bone lesion is very common in these kind of cases, and axial skeletal predominance. So the skeletal so lordosis phacosis, there are two different conditions again we studied in biomechanics in the unit 1 itself. So these are all like affecting the skeletal bone, which will have some deformity happening inside it, and it will reflect in the mobility purpose of the individual, and then it is followed by rapid progression. So when you see it in the primary bone tumors, it is like a slow progressive. It will take years of time to reflect in the body, so that it is like very difficult to find in the early stages. But the metastatic diseases are like in a very short span, it try to spread throughout the body, and it will expand in an enormous way, and it will become visible very shortly. And the last point is about like associated systematic symptom, which will give a clear sight about that particular patient who are under these kind of problems. Okay, so the most important point about this clinical scenario that I have discussed with you in the classroom: a 60-year-old patient represented the new onset back pain and a destructive lytic lesion identified on X-ray imaging. So this multiple myeloma is a kind of a condition behind it, and the age appropriation with respect to the pain and lytic lesion is happening. So we are going to check the serum protein electrophoresis and urine for Benz-Jones proteins, and all the other factors we will check. So this is like first point, and then like metastatic cancer, like very high possibilities are there. If you ask me, like if the patient has a history of breast, lung, prostate, or kidney cancer, then we need to evaluate like known primary, and whether we need to consider the tumor markers, because that is the first thing that we need to do. If there is any history of cancer has happened previously, it's quite common to check for it, and that will give a clear insight about. So when you are trying to give a solution for this, you should have this in your mind. And in the primary bone tumor, so it is like very that less likely it might happen, very rare. So in this age group, but chondrosarcoma and other primary tumors remain in differential state, and which requires biopsy for definitive diagnosis. Again, this biopsy is one of the main factor that we need to know, which we feel like if any of the part of the bone is subjected to these kind of problem, we will take a biopsy out of it, and it will be given to the lab for testing, and we will come to know whether there is a tumor occurrence is there or not. And once it is like not shown, and they'll go for like blood related test also. Sometimes the blood will show some kind of inflammatory responses, which might tell you that there is something like bothering the body, which will also be a possible. But most probably, if there is any case like which has a history of any kind of cancer, they'll go for marking test and stuff. So these are all the points that you need to keep it in mind for assessing the case that we discussed today. So watching this video will give you an insight like how or like how to approach the problem that we discussed in the class, and you can come with an insight and a solution for this. Thank you.